Gail.
Thank you very much, George, and thank you for those very kind comments. On the committee, we recognized that graduate medical education is only one component of trying to help transform our current delivery system away from a volume-driven, cost-based reimbursement system to a high-performing, value-based healthcare delivery system. Many other issues will need to be resolved if we're going to be successful in this transformation, like reassessing how we pay physicians and other healthcare professionals, selective loan forgiveness, and other strategies to try to help change the distribution of professionals who are trained and where they locate. But having said that, we recognize that graduate medical education could be important in terms of helping to develop the physician workforce that would lead the movement toward a high-value healthcare system. That at least under our current system and in the near future, physicians remain the captains of the healthcare team, and having them be trained so as to participate in a high-performing, high-value healthcare system was critical to making this transformation. The committee, unlike some of its predecessor groups, truly struggled with explaining and justifying the rationale of having federal government funding for graduate medical education because of the absence of significant federal government funding either for undergraduate medical education or for other areas of healthcare professions or other areas that are important to society and in short supply. But regarded the leverage that a repurposed and repositioned Medicare funding for graduate medical education could play in helping develop the physician workforce for a 21st century delivery system as too important to forgo. And what we have recommended, therefore, is a series of changes that would better accomplish these objectives and a reassessment after a decade to see how well the reforms have worked, and also to assess again the question of whether there was further justification. I'm just going to mention briefly what it was that we've recommended, which is basically moving to two funds, an operational fund, which will be the basic funding for residents, initially those who are currently receiving funds and in accredited programs, and secondarily a transformation fund, which will be responsible for piloting many of the innovations that we hope will be considered in terms of distributing funds, of developing performance and other relevant metrics, and for providing a funding source for residencies either in specialties or in areas that have been in short supply. That we move to a national per resident amount that is geographically adjusted, and that we do this by combining the two current funding streams, the direct medical education and the indirect medical education, into a combined funding stream that would then be divided into these two different funds. We think it's important to have a policy infrastructure and a financing infrastructure. We've recommended that a policy council be developed in the office of the secretary, adequately resourced, and that a GME center be developed in the Centers for Medicare and Medicaid Services that would be responsible for the distribution of funds and have that done in a way that is consistent with the directives of the Policy Council, which would be assigned the responsibility of assessing workforce needs for the country and also integrating the various groups involved in terms of producing the workforce. I think it's important to have a gradual movement that occurs within this decade, although we prefer to start immediately, recognizing that institutions need some time to adjust, and that the current system therefore be phased out at the same time that this new system is moved in. And finally, we want to continue allowing for Medicaid to be used at the state's discretion to fund graduate medical education if states wish. Most do now, although to varying degrees. But we think the same kind of accountability and transparency that we are recommending be adopted for Medicare should be adopted for Medicaid. Again, it's a question of good governance, of justifying the use of public funds in a way that are consistent with meeting national goals and having it be clear to the public what it is they are receiving in response for using public funding.